Good morning. Welcome, everyone. We'll get started soon. Let's give folks a few minutes to log on, and we'll start momentarily. Give it another minute or so. Looks like it's winding down. Alrighty, let's get started. Let's see. Hello, everyone. Welcome to the CalAIM Reentry Initiative Learning Collaborative office hours. As a reminder, please remember this is a forum intended for state, county, correctional facilities, and behavioral public health agencies. Let's see, there we go. While the presenters are speaking, all attendees will remain muted. If you would like to speak, please use the participants tab. Click on the three dots next to your name and select ask to mute or ask to unmute. Please utilize the Q&A box for questions only. Thank you for your cooperation and ongoing support of the CalAIM Justice Involved Reentry Initiative. Let's see, let's go to the next slide. And let's get started. Let's talk about our timeline. Let's see, today is the correctional facility office hours for session 4, which was the non-behavioral health services. An additional office hour session open to everyone else outside of correctional facilities will occur on October 31st. Our next Learning Collab training session for November will be on enhanced care management for the JI population of focus. Also to note, we will only host one office hour in November due to the Thanksgiving holiday. So next month's office hour will just be a general office hour for everyone. As a reminder, facilities may enroll for any session via the Medi-Cal learning portal at learn.medical.ca.gov. Next, we had 21 open questions from the last section that were left open, and we have responses for those now. So next session, or next slide, actually. All right, question number 1. Are all correctional facilities required to participate in the initiative, or can they opt out? As a reminder, state prisons county jails, county youth correctional facilities are required to participate in the initiative and according to state law mandates. All correctional facilities must go live no later than October 1st, 2026. So once again, it's just state prisons, county jails, county youth correctional facilities. Next slide. Question number 2, will correctional facilities need to develop programs that meet Consolidated Appropriations Act of 2023 requirements and the Justice Involved Reentry Initiative? And I'm gonna this is a long response and we'll send this out to you, but the gist of it is we got permission from CMS to fold in the CA federal requirements into the initiative, and that will occur over a 2-year implementation period through October of this year through October of 2026. This means that if a correctional facility is live with the JI initiative, they are meeting the federal CA requirements. We'll provide additional guidance on meeting these requirements, including the scope of services that are covered through the updated policy guide that we will be releasing at a later date. Question number 3. Next slide. Sorry. When will DHCS release the correctional facility and managed care MOU? We expect to release that in the first quarter of next year. We require MOUs between the correctional facilities and managed care plans in their counties or regions of operation, including state prisons. Additional details, including the timelines of this requirement, will be shared once those MOUs will be released. Until that point, managed care plans may, but they're not required to execute MOUs or contracts with the correctional facilities in their county or regions of operation. Next slide. Question number 4. Once the incarcerated individual is active in the JI screening portal, how long does it take for this to be reflected or updated in MEDS system? For claims and eligibility verification purposes, the JI code will be reflected active in real time to allow JI services to be provided and billed for as soon as this information is submitted to DHCS. However, the JI code will not be reflected in MEDS until the daily batch update processes occur, which may be the next business day if that transaction occurs after 5 p.m. or on the weekend. Okay, and next slide. All right, question number 5. How will the JI code be reflected in the daily, monthly 834 file sent to managed care plans? Will the JI code be removed from the individual upon their release into the community? Incarcerated individuals with a managed care plan in hold status will be noted in the daily or monthly 834 file. Oops. Can everybody hear me? Just give a thumbs up if you can. Okay, cool. That DH shares with managed care plans. This applies to any incarcerated Medi-Cal member with suspended primary aid code and a managed care plan, not just those receiving pre-release services. The 834 file will also include a JI indicator when the JI code is activated, alerting the managed care plans to the JI population they are responsible for. Upon release and reentry into the community, the primary aid code will be reactivated and the JI indicator will no longer appear in the 834 file. Next slide. Question number 6. And if an individual's pre-release services were paused, should they be restarted via a restart or via a reset? When an individual's GI code is reinstated by a correctional facility after a temporary pause, the GI screening portal will determine whether the benefits require a reset or restart and take the appropriate action during activation. Each individual is allowed one preset per incarceration. If they experience multiple qualifying events but have already used their reset, their 90-day pre-release services period can be paused and then restarted with the remaining days. There is an exception. Youth incarcerated at youth correctional facilities are not subject to any limits on resets. For more detailed information on when to pause, reset, or restart, please review the information shared in the Learning Collaborative 2, and we have the link to the recording that's available. Next slide. Let's see. Is it possible for facilities to test the GI screening portal functionality prior to their go live with pre-release services? No, the GI screening portal is in a production environment and is not intended for testing purposes. Resources for using the GI screening portal are available here. There's actually a training link that you guys can take the trainings for. Also, the GI Reentry Initiative Screening Portal user guide that we provided the link for. Next slide. What is a ORP provider and what entities need to enroll under that category? An ORP refers to ordering, referring, and prescribing providers, otherwise known as a clinician, ordering, lab, referring to a physical therapist, or prescribing medications. Federal Medicaid law requires all ORP providers to individually enroll in Medicaid. DHCS expects all ORP providers who furnish GI Reentry Initiative services to individually enroll in Medi-Cal with some expectations, or with some exceptions, sorry. The correctional facility may receive approval to waive an ORP requirement as part of the readiness assessment based on certain extenuating circumstances. DHCS is available to provide technical assistance to complete this enrollment, and there's more information on our website, and here's the link for that. Okay, next slide. Question number 9. Do all on-site correctional health care providers need to be enrolled as Medi-Cal providers to bill for pre-release services, or does only the correctional facility need to be enrolled within MPI? We expect that all correctional facility clinics obtain a Type 2 NPI and enroll in Medi-Cal as an exempt from licensure clinic. Note that enrollments may be on an agency or county level. Individual practitioners within the correctional facility will not need to enroll independently as providers if they are operating under the correctional facility NPI and are not an ORP provider or a care manager. Question number 10, next slide. What Medi-Cal enrollment requirements are there for county behavioral agencies? If the county behavioral provider is already enrolled in PAVE as a billing provider, no additional action is needed at this time. The agency can verify their current enrollment status by visiting the Open Data portal, and there's the link there. And if the behavioral health provider is currently enrolled as an ordering, referring, or prescribing provider and would like to bill directly for services provided, a new billing application will need to be submitted in PAVE. Applications are location specific. Each location providing services is required to submit a PAVE application. Next slide, question 11. When should short dwell be billed for behavioral health links, and when should CAMUS be billed? Short dwell is only billed in pre-release period when county behavioral health agencies are acting as a plan and receiving behavioral health links. The agency must bill Medi-Cal fee-for-service via CAMUS for all other pre-release and behavioral health link services. The short dwell Medi-Cal service table for fiscal year 24-25 can be found on the Med-CC library page. Each service table has a column titled GI Warm Linkage Code. Each code with a yes in the column is considered a code that is billable as part of the behavioral health link. Next slide, question 12. Would Tier 1 screening be considered a clinical consultation and thus be billable for under CAMUS? No, Tier 1 screening is done to see if the individual is eligible for pre-release services. The results of this screening will trigger the GI code activation. This screening could include a record review of current diagnosis or treatment or self-attestation. Because the individual will not have an active GI code at the time of the screening, and the screening will likely not include clinical services, it is not eligible for reimbursement. Next slide, question number 13. When can a correctional facility bill for lab or radiology services? Lab and radiology services may only be billed under correctional facility MPI for services completed by the correctional facility or their contracted providers. For example, if a correctional medical staff takes x-rays on site and then sends x-rays to their contracted provider to be read by a radiologist, both of these services would be billed under the correctional facility MPI. If a correctional medical staff draws specimens, samples, or blood for testing and sends this test to the contracted community-based lab, both of these services would be billed under the correctional facility MPI. All correctional facility and contracted labs must be CLIA certified in order to receive Medicaid reimbursement. More information is available under the clinical lab provider application information link on our page. Next slide. Question number 14. Are services provided by licensed social workers and MFTs, health risk assessments, reentry plans billable if a licensed provider co-signs their notes? Yes. If the licensed provider is overseeing the work and the individual is following state and federal regulations about scope of practice, the work is billable. Question number 15. Will individuals receive eligibility determination or notices? Incarcerated individuals will receive a notices of action or a NOAA when an eligibility determination is completed at application or during incarceration, upon activation at release, and when approved or denied for 90-day pre-release services. Notices will be sent to the individual's address on file, which may be the correctional facility. Next slide. Question 16. Are former foster youth up to age 26 eligible for 90-day pre-release services without meeting a health need criteria in both adult and youth facilities? Answer is yes. All Medi-Cal CHIP eligible youth under 21, and former foster youth under 26 housed in youth or adult correctional facilities are eligible for 90-day pre-release services regardless of the facility in which they are held. Updated language on CAA eligibility will be included in the forthcoming updated policy and operations guide. Next question, question 17. Is DHCS aware of any legal restrictions prohibiting correctional facilities from asking individuals under the age of 26 whether they have history in the foster care system? DHCS is not aware of any specific legal prohibitions in asking if anyone is former foster youth in the context of asking for the purpose of determining eligibility for Medi-Cal services. This does not constitute legal advice, and DHCS suggests correctional facilities check with their county council. DHCS is currently working to determine best practice methods for correctional facilities to identify the foster and former foster youth population, and will provide additional guidance at a later date. Question number 18, next slide. Do individuals with the Medi-Cal fee-for-service or full scope benefits need to reapply for Medi-Cal if they want to switch to managed care? No, a Medi-Cal application is not needed for someone already enrolled in Medi-Cal. Individuals who are not enrolled in managed care but are subject to it based on their aid code and county of residence will be auto-assigned to a managed care plan in their county of residence when the JI code is activated. These members will receive a choice period and an opportunity to change plans upon their release. A choice packet will be mailed to them upon release. Those members who are exempt from managed care will remain in Medi-Cal fee-for-service upon release. They can enroll in managed care upon the release should they wish to remain. Question number 19. What entities are eligible to provide ECM for the JI population of focus? How can correctional facilities make connections to community-based JI ECM providers? To be considered a JI ECM provider, an entity must meet standard ECM provider requirements as described in the ECM policy guide. Participate in pre-release care management services as in reach provider and accept warm handoffs and bill Medi-Cal fee-for-service for all pre-release care management services and warm handoffs. Correctional facilities should connect with managed care plans in their county to make connections with existing JI ECM providers. All managed care plans employ a JI liaison. Contact information publicly posted on their website, who can serve as the primary contact for correctional facility staff. Please see section 8.4B of our policy and operations guide for more detailed guidance on the expectations for pre-release in-reach care manager and post-release ECM provider assignments. Next slide, question number 20. Who is responsible for developing a housing plan for individuals? As part of pre-release care management, the pre-release care manager must complete a health risk assessment for each individual, which includes identification of planned housing upon release and any housing need in the community. Upon identification of any housing need, and the pre-release care manager should work to address those needs in partnership with the individual's assigned managed care plan, assigned post-release ECM provider, if different, and community resources. The individual's housing plan should be memorialized in their reentry care plan. Next slide. last question, how should the managed care plan proceed with coordinating referrals with community providers when the member is not active in the managed care plan's eligibility file? Eligible individuals will be assigned a pre-release care manager during their 90-day pre-release period, who is responsible for, amongst other pre-release care management tasks, coordinating, scheduling, and conducting warm handoffs to require reentry services and providers, and which are also primary care, specialty care, mental health care, substance use care, housing needs, managed care benefits, including non-emergency medical transportation, managed care plan, community supports, and more. Managed care plans are expected to support the pre-release care manager in coordination of referrals and connections to post-release services for any individuals assigned to their plan and in a hold status during their period of incarceration. Next slide. All right, that's the end of our open questions that we had at the end of our last session. Now let's dig into any of our office hour questions that you guys have in our QA, and I'll hand it over to Megan and Maya to lead us off.
Hello, everybody. We're going to open it up for some live Q&A now, and you may go ahead and submit questions with using the Q&A button at the bottom of your screen. And Maya is going to so graciously tee up all the questions for us and keep us a little organized during this time.
Thanks, everyone, and good morning. This is Maya Shasha with Manat Health. I think let's get started with a few of the questions that have come through and have been answered, but I think would be helpful to speak out loud because they're common questions that the team receives. First one being a question about whether clinical assessments can be conducted as a behavioral health link service if they are provided via telehealth. Ashley, I know you put that in the chat, but Megan, you may want to speak it out loud instead, so either of you.
I'll go ahead and take it. I think Ashley is busy responding to others in the Q&A. As part of the CalAIM JI pre-release services, eligible individuals will receive behavioral health clinical consultation services provided through telehealth or in person as needed to diagnose any health conditions, provide treatment as appropriate, and support the pre-release care manager's development of a reentry care plan and discharge planning. So all of that to say yes.
I'll just add a little bit onto that. From a behavioral health agency or a community behavioral health provider's perspective, clinical consultation is, for JI purposes, a separate billable activity from behavioral health links. So clinical consultation can be done for treatment or stabilization of conditions. The behavioral health linkage is specifically designed to sort of hand off care from the correctional facility to the behavioral health agency. And the important distinction is these two are billed through two different systems. The behavioral health linkages are billed through short DOIL for the behavioral health agency, and the clinical consultation activity would be billed through our CAMIS fee-for-service system. Thank you.
Thanks,
Thank
Brian.
you for that clarification, Ryan. That is very important to understand.
And Scott, I see that you had another question in asking, I think, what Brian just addressed, but if you had another follow-up to that, if you'll just drop that in the Q&A again, let us know. Otherwise, Megan, I saw that you had your hand up, Megan West from Placer County, if you had something you wanted to raise.
Yeah, it was expanded on by Brian, so I think I'm clear now that the clinical consultation service Ashley is referring to is indeed being considered a pre-release service and not billable by the mental health plan as short DOIL.
Great.
Okay, thank you.
Thank you. All right. And just for one of the questions that was also already asked, and Megan, you had dropped in a response, we got a clarifying question from Tanya asking about unlicensed staff providing many of the care management services that are a part of this initiative, whether it's form handoffs, reentry care plan development, and asking about what the expectations are for unlicensed staff and their supervision by licensed staff, if that's okay as a part of this initiative.
Yes, I believe we covered this question in the slides earlier, but if the licensed provider is overseeing the work and the individual is following state and federal regulations about scope of practice, the work would be billable. Again, yes, as long as the licensed provider is following all applicable state and federal regulations about the scope of practice.
I just want to make sure that I clarify one point. Like, this isn't just about like a MSW that's registered with the board but not licensed yet. This is also like health worker level staff. Okay, just everyone shaking their head. That's great news. Thank you.
Thanks, Tanya. Good question. And if you need the reference, I think that's on the question 14.
Thank you so much.
I see a hand up from Daljeet.
Hi, thank you. So if a member is not connected to county behavioral health services during pre-release, what are the expectations from the managed care plans in coordinating that behavioral health linkage?
Are you referring to like a referral or behavioral health link that is conducted for non-specialty mental health services?
That's correct.
Okay, so that I believe that is covered in section 13 of our policy and operations guide about the managed care plan expectations. Essentially, you'll be receiving a warm handoff for that individual and then coordinating with the pre-release care manager to address any areas of the reentry care plan that have been identified for that individual, such as housing needs or transportation needs to their post-release appointments. All of that gets coordinated during the warm handoff meeting. And then as soon as they're released, executing those appointments and those services. Does that make sense? Or
well, I think what I wanted to know was if a member does have, let's say, not like a significant mental illness, right? Like if they have a diagnosis of anxiety, for example, what is the expectation from the health plan? Are we connecting them with somebody from like behavioral health point of view, like we have behavioral health within the health plan? Is there an expectation for us to connect that member with the case manager to help them with their BH needs?
yes, the individuals would then have their behavioral health link facilitated through the care manager or the ECM provider.
Understood. Thank you so much.
You're welcome.
Wonderful. All right, I see a question that came in from Dennis asking if there's a standardized assessment that will be used in all correctional facilities if DHCS is potentially providing a standardized assessment. Megan, not sure if you want to take this or others from the team.
I could do my best, but if others have some more clarification, please step in as well. So at this time, we're not going to be developing or releasing a standardized assessment. We've provided several examples of thorough assessments in our policy and operations guide. And then we're encouraging the correctional facilities and behavioral health agencies to come to an agreement on the acceptability of different assessment templates that the correctional facility wants to use to identify the needs and go from there. So if anybody else from our team has further clarification on that or some more information, that would be welcome to.
I can speak for a moment, Megan. We have the types of assessments for different substance use disorder or behavioral health issues, but none of them, as Megan said, are required. We do look at the ASAM criteria for placement in behavioral health circumstances, and the final piece is you can really use what you're using. It just has to have some kind of evidence base behind it. So we don't want you to stop what you're doing if you're doing something that works. We want you to just make sure that it's a validated tool. That's the bottom line.
So I think my question is really, thank you for that, right? hear you on the evidence base for like mental health and substance use, but I'm also hearing a lot of discussion around housing, right? So I think my recommendation would be it would be really helpful to ensure that the different domains you want to have assessed are clear and required. And I totally agree with the fact that you're not dictating you have to use this tool versus that tool. However, I think it would be helpful if DHCS was very clear, like you must assess for public benefits, you must assess for housing, stuff that may feel like common sense to the presenting group, but based on my experience with our ECM providers are in very different stages of learning how to do ECM in the comprehensive way DHCS envisions, and that level of topic guidance would be extremely helpful.
I totally understand. One of the things to think about with that as well is those things are happening, but they're not necessarily happening all at the same time, depending on where the member is in their 90-day pre-release process. So, and I see Brian's off, so I'm going to defer to him.
Yeah, Dennis, I think those points are well taken. We do have those domains that are required to be assessed for throughout the policy guide. We will have additional guidance in the new policy guide when it comes out. I think how people are assessing and sharing best practices among the counties and entities will be an important future activity we'll want to look into, where we're not going to put out very specific guidance about which types of assessments. We'll want to have people talking to each other about what's working and what they're doing.
Thanks all. All right, next I think we'll go over to a question from Gail Haberman. And I think I'll pass it to you, Ashley, but the question is, besides the professional to professional clinical consultation, can a post-release behavioral health agency bill Short Doyle for a visit with the client pre-release that is not treatment?
So all pre-release services are actually billed via fee-for-service through CAMUS. And it's only the receiving of that behavioral health link that the behavioral health agency would bill Short Doyle.
So I don't know what is meant by a visit that is not treatment. But I would just, as Ashley and Megan have alluded to, we have categories of things that are billable. I would look to the definitions of what those things are. We have guidance around what qualifies under clinical consultation, both on the behavioral health and the physical health side. We have definitions of what qualifies under the behavioral health linkage. I know this sort of applies to another question I think we got about transferring medical records from a behavioral health agency to a correctional facility to help that correctional facility design some treatment prior to release. Now that in and of itself, unless it is connected to a clinical consultation visit, I don't think transferring records, even though we encourage it on the front end, is really a billable service. But if it is done as part of a clinical consultation and everything's satisfied for a clinical consultation, great. Certainly the warm linkage handoff can be billed by the behavioral health agency at the appropriate time, whenever that is, and information sharing can be done as part of that as well.
Can I just follow up on that? Is that okay?
Yeah.
Okay, thank you so much. So if a behavioral health agency beyond the professional to professional handoff meeting wants to meet with a client pre-release to either just sort of evaluate whether they're not a clinical consultation per se, but just to evaluate whether they're a good fit for a program, or to build a relationship pre-release in the hopes that that will encourage the client to show up for treatment. Are either one of those billable under Short Doyle if it's just between the behavioral health agency and the client, and the pre-release care manager, the pre-release clinician is not there like the requirement is for the professional to professional handoff? That's what we're trying to figure out.
And as a jail provider, I want to strongly advocate for that to be billable, because it is best practice for the community behavioral health provider to continue to follow their patient while they're in custody. And they really should be the one developing the release plan, because the release plan should speak to what's going to happen in the community, and they are the ones that should be defining that. We have long had community providers continue to follow their clients in the jail without being able to bill. And this is an opportunity to change that, because it prevents disconnection and isolation that occurs during incarceration. It's best practice from a healthcare perspective. And we want to encourage that whenever possible, that they continue to be the lead on the patient's care once the person is released, and that starts during incarceration.
I think
Tanya said that so beautifully. I just want to thank you. And yes, just to say, this is what I work with LA County mental health, and what we're hearing from our jail partners is when our staff go in pre-release to meet with the client to build that relationship, not only what Tanya just said beautifully, but also it's the greatest indicator of whether they will show up for post-release care. We don't have good data, I'll admit, on this, and we're going to start tracking it better, but that's what anecdotally we feel. And so we can't bill for any of those visits, and we can't, so we're not quite understanding of whether we can, under short Doyle, bill for any of these visits other than the professional handoff.
I'm from behavioral health in Imperial County, and we actually we're considered an in-reach provider. So we do meet with the clients in the jail, and unfortunately the DHCS has yet to prove our readiness assessment plan, but that would be billed under the fee for service, those services under assessment or care coordination, if you're providing those pre-release services in the jail. You won't be able to bill short Doyle, but you would bill under the fee for service.
So we can't bill free for service because we are not an in-reach provider. So a different health agency is providing all of the mental health services while clients are in jail. But when we're the post-release provider and not the pre-release provider, we are not able to bill. And we thought we were now going to be able to bill for these visits under short Doyle, and now I'm hearing no, so I'm a little bit confused.
Say you could still bill because you're considered an in-reach provider, because those are the ones who are providing the services, the mental health, like let's say the jail's provider, medical providers providing the mental health services, they're considered embedded. So you're still considered as an in-reach provider, and you can bill for the service because you're providing that linkage pre-release for the purpose of post-release services. That makes sense.
I would say that sounds right. I believe we have a wide range of E&M codes that were also short Doyle codes that fit under clinical consultation. And it is very likely that a lot of these activities you're talking about qualify under those codes. The difference is they are billed under fee for service under CAMAS. We have migrated a whole bunch of those codes over into CAMAS so that they can be billed for the same types of activities that are under clinical consultation, and it's a wide range. So if you say, nobody may have contracted you to be an in-reach provider, but if the jail allows you to come in to visit with that person, and that thing that you're doing fits under the fee-for-service clinical consultation category, you should be able to bill JI for it. I'm going to ask anyone on my team if anything about that sounds not quite right or needs to be clarified.
It all sounds right to me, Brian.
So that means, we have 1,000, contracted providers in LA County who aren't going to be on CAMAS. So what you're saying is, in order for this to happen, they can't bill under short Doyle. They have to bill under CAMAS.
That is correct for the clinical consultation category. And I do recognize that presents a new.
Yeah, that's quite a barrier, but thank you for clarifying. Okay.
Megan from Placer County, did you have your hand up for a follow-up on that, or was it addressed?
That was addressed, explaining that you want behavioral health to register with CAMAS as a fee-for-service provider to provide these services, clinical consultation during pre-release.
Great.
Then can you clarify that though? It was my understanding that to register and bill fee for service in the correctional facility, you also need to be contracted with the correctional facility since billing is going to go through them as an entity.
This would be considered an in-reach provider service, and in-reach providers bill under their own NPI and billing pathway. They would not be billing through the correctional facility's exempt from licensure clinic. So if it's something that the correctional facility wants to have that provider come in and do that service, certainly the correctional facility has to allow it, but it doesn't have to be, strictly speaking, contracted for or billed under the correctional facility's exempt from licensure clinic. It can be billed by that provider directly through fee-for-service CAMs.
Great. I see Joe, you have your hand up if you wanted to chime in.
Hey, I think this is in the same lane, and I put this in the Q&A, but maybe I can follow up. So my understanding is that on the 15th, the Medi-Cal rates file was updated to reflect some of the CPT codes and HCPCS codes that we're talking about here, right? So I've downloaded the new file, which is great, but I'm having a hard time identifying the CPT codes that I think we're talking about from a behavioral health services provision. So on one table, I have the provider website that has like an Excel doc, right, of all the different CPT codes, and sometimes it says like 99231 through 99236, and I have the Medi-Cal file on the other side. Is there, rather than me kind of like trying to like merge the two to kind of figure out which in the Medi-Cal file we should be looking at for these services, has that work already been done, or are we required to kind of do that merging ourselves?
I am going to defer to anybody else who has an answer on this. If nobody does, I'm going to say we can take this back and check in with our billing guidance folks on how best to accomplish that and get back to you and others. Anybody have an answer better than that?
Dee Dee, it's a bit hard to hear you.
Still quiet, Dee Dee.
Dee, if you're having audio issues as well and you want to type out what you have to say, we can maybe circle right back around to this. And someone from the team can read out whatever you had to share. Thank you. And thanks for bearing with the tech. And thanks all for that really rich discussion. All right. While we're waiting on that follow-up, I'm gonna move to a question from Rebecca, which asks, once an individual has been released to a community treatment provider, what will be the pre-release care manager and or post-release enhanced care management provider's responsibility, role, and function? I think Megan can pass to you to get things started.
Yes. So once an individual is released to the community, their care management is the responsibility of the ECM post-release care manager. Does that answer the question, or can we clarify or expand a little bit more?
Thank you, Megan. I think to expand on that. So currently we do have ECM a team working with some of our individuals that are coming out of custody. However, there's a bit of confusion at times when individuals are then enrolled to a provider, and then the ECM team is then recommending a different level of care and submitting those requests to the courts. So I'm trying to understand, whose responsibility is it once the client gets released? Is it the community provider, or is it the pre-release, post-release team that would be responsible for that client?
So once the individual is released, it is completely community-based. It would be the post-release ECM provider and the managed care plan's responsibility for care. pre-release care manager will not have any more involvement once they're released.
In the
And
post-release,
that kind of is, that's going to be typical for your longer stays and people with identified release dates. Part of our short-term model requires that if an individual releases before a warm handoff can take place, that the pre-release care manager would make contact post-release within a certain time period to relay any information, treatment history, and information to the post-release provider. So aside from that requirement, there won't be any more interaction post-release between the pre-release care manager and the ECM provider.
okay, thank you. Appreciate that clarification.
And I see Brian's off mute, so please help, Brian.
Yeah, Rebecca, I didn't, I'm not sure I totally understood the question you're talking about, the division of responsibility between a community provider and the ECM provider. Really, post-release, it's a three-way relationship between the managed care plan, the managed care plan's contracted ECM provider, and whoever the community provider is. If we're talking about on the county behavioral health side, then that relationship is a little different, where the ECM provider is a little bit more arm's length. If we're talking about a contracted managed care plan community provider for non-specialty mental health services, then that relationship is even a little bit tighter. But if you have other questions, let us know.
Thanks, both of you. And we've gotten our response, Joe, from Dee Dee, who's with the CAMIS team. So I'll just read that out to you. And then if there's follow-ups, please let us know. But Dee Dee shared that there is no merging of or separate location of codes and services for JI and their rates. So as a Medi-Cal provider, you have the codes and then have to go to the rates page to see the allowable payment amount. So let us know if there's any follow-up to that. I think maybe if you're willing to pop it in the Q&A so we can do a written response, since that might work better with the AV issue. That would be great, but hope that helps address your question. Moving on, we've got a question, which I think I'll kick over to Sarah Linder, asking if the eligibility file to manage care, plans does not include a member, how DHCS suggests approaching referral coordination, for example, to primary care, to a specialist or other providers, because they may face issues with showing that the member is ineligible.
All right. So I don't anticipate that this is going to occur too often, as all of our individuals that are eligible for JI have to have a primary or established Medi-Cal eligibility. And the majority of our population does fall to the managed care delivery system. So incarcerated individuals with an assigned managed care plan at the time of incarceration will have that plan enrollment put on hold if they're incarcerated for more than 28 days. And so individuals with a managed care that's placed on hold or the enrolled will be noted as such in our 834 files that we already share with the managed care plan. So this process exists today. But for those that are incarcerated without a managed care plan, we will be initiating the managed care plan default enrollment at the time the JI aid code is active. So depending on the timing of their release and the timing of the activation, there may be individuals that are not yet enrolled in managed care. And so in those instances, they would not be reflected on the 834. And I think team, correct me if I'm wrong, we have processes in place for the billing of the fee for service, but I don't think there would be any responsibilities on the managed care plan until the individual is enrolled. But those that are enrolled and they are put in a managed care plan, they would have that put on hold, and then upon their release, they would be active. So the enrollment is going to shift from a hold status to an active status on that 834 through the HCP status code. And once we have the JI aid code activated for any of those individuals, the JI indicator will also be reflected on that 834 so that the managed care plans will be able to identify those individuals and start coordinating the care. So only in a small instance would we anticipate the individuals that went into incarceration without Medi-Cal or without a managed care plan enrollment would not be enrolled prior to their release. Does anyone want to speak to from the OSP side on the coordination that would be required or not be required for the individual that's not yet enrolled in a managed care plan as part of the reentry process?
Just a couple thoughts. It's not a perfect situation. It would be ideal to have everybody come out with Medi-Cal and enrolled in a managed care plan so that the ECM provider who works for the managed care plan can have all the appointments ready to go with the managed care plan's contracted providers or with county behavioral health. So in situations where you don't have somebody already enrolled in managed care, we do have the ECM provider who is somebody who is contracted with the managed care plan. They will be able to continue their services, billing fee for service, and they have some familiarity with the managed care plan, which will hopefully help them get things coordinated to the extent possible. And hopefully that managed care plan enrollment happens pretty fast. Fee for service providers are available. Maybe the ECM provider can focus their efforts on fee for service providers who are also contracted with the managed care plan if they're aware of those things, so that there's some continuity from that fee for service period to the managed care enrollment period. That's all I've got.
Thanks. And I would just add, we are actively working on improving our enrollment processes so that we have quicker enrollment, as sometimes that can take 30 to 45 days, depending on the timing, as it exists today. So I think we anticipate that shift coming in mid-2025, and that'll really reduce the amount that we see this and help get those people enrolled in managed care as soon as we can.
May I ask a quick follow-up? Since I'm not that familiar with the 834 file, are you referring to a monthly or a daily file?
I believe they send multiple different variations of it, but I do know for sure there is a daily 834 file that's communicated to capture the changes from the day-to-day eligibility as it exists today with our managed care plan population.
Thank you.
Thank you both. I'll go to a question that got answered, but I think is useful to speak out loud from Scott from Placer County, asking about whether DHCS has a required mental health screening tool, which will be used to determine whether an individual is referred to their managed care plan versus to the county mental health plan. Megan, if you're willing to talk it out loud.
Yes. So I believe the screening tool that Scott is referring to is the Screening and Transition of Care tool released via Behavioral Health Information Notice, I believe in late 2022. At this time, DHCS is not going to require the use of the Screening and Transition of Care tool during the incarceration period. And ultimately that was decided because this tool was not designed to be utilized for this purpose. And instead, we are encouraging the county partners to discuss level of care needs during the warm handoff or behavioral health links meeting. An important note to that statement is that there are certain frameworks in place during the behavioral health links screening process to identify behavioral health needs versus SED needs. And those would trigger it's outlined in our policy, but those would trigger a certain level of care referral. Essentially, it would dictate to the correctional facility if that individual would be better served by their managed care plan and non-specialty mental health services, or if they do need a behavioral health link to their mental health plan. Again, that would be section 6.4 in the policy and operations guide. Did I answer the question, Scott, or?
Yeah, no, it sort of does, and I can expand a little bit. I have downloaded and reviewed the suggested screening tools within the policy guide, but none of them make a distinction between a managed care plan and specialty mental health referral. What they pretty much say is additional assessment is needed. So I'm wondering if the clinical assessment is the method to determine whether or not a managed care plan or specialty mental health plan referral is needed if we're not going to be using that DHCS issued screening tool, which determines that.
Yes, so individuals will receive a clinical assessment. So there's different levels of screening and assessments identified in the policy guide. Tier 1 would be your initial screening upon entry to the correctional facility, essentially. There is a more thorough assessment required later to develop the health risk assessment and the reentry care plan. And at that time, if those behavioral health needs or substance use disorder needs are identified, then that would trigger a behavioral health link to be required. So again, that's 6.4 in the policy policy and operations guide. I think it is spoken to in more detail also in I think 11.4 is the behavioral health links section of the policy guide too.
Megan, would it be fair to say,
Brian.
would it be fair to say, even though we are not recommending that tool that is linked in the behavioral health information notice, because certain questions are not appropriate for a correctional facility environment, would it be fair to say that even with that, it gives you a pretty fair idea of what the criteria are for specialty mental health versus not?
It does give a good picture of the different criteria for to be met for specialty mental health services versus non-specialty mental health services. But because some of the questions are not designed for an individual who is currently incarcerated, it would not be very reliable to use to actually determine placement. Does that provide enough clarification? Okay, perfect.
Thank you all. And I hate to cut us off, but we've come a little bit over our allotted time and want to acknowledge that we've got a couple questions in the Q&A that have not yet been answered. The team is going to take this back and work to provide answers as a part of the ongoing office hours sessions. As you see, we have that deck and we'll integrate that in here. And if there are any follow-ups, please contact the team via their email. But Megan, I will pass back to you to close us out.
Yes, thank you so much, everybody, for attending today. We look forward to hearing from you guys, and the feedback that you're providing is very critical as we implement this program. We are the first in the nation, and that comes with some growing pains and some learning opportunities. And so we are excited to learn from you guys who are implementing. If you haven't done so already, please register for our learning collaborative session. The next one will be Thursday, November 14th. And then please visit the Medi-Cal learning portal to register for and access the JI portal and Medi-Cal billing training sessions. And of course, if you have any questions that came up during our discussion today or that come to mind, please email us at CalAIM Justice Advisory Group at dhcs.ca.gov. And we hope you have a wonderful rest of your day.
Thank you so much.